Hello, everyone. Welcome to week number 2. And in this screencast, we're going to be looking at measuring health and disease. So here is the breakdown for this week. Couple screencasts. This particular lecture, the main lecture, is going to more than likely be divided into 2 smaller screencasts. So I tried to keep each screencast around 20 to 25 minutes. So this one may be broken into a couple, and then there is another screencast which is illustrating what I'm looking for when we do your presentation. Your homework is on Canvas, and the scoring rubric is on the homework sheet. What I mean by that is each of the individual questions, it will state what the number of points are for that question. To do the homework, you need to review the Marin and Guthrie articles. Now, last week I talked about having you review a couple articles. And the purpose of reviewing those articles is just to start to expose you to epidemiologic studies, not for you to become an expert in the article's topic, but to start to look at the design of the study and to get an appreciation for tables and figures. And let me talk about that in here just a moment. So with Brock et al., this is a prevalence study. So they're looking at prevalence of low bone mineral density in female adolescent runners and collecting a lot of other measures in order to determine if those traits are associated with low bone mineral density. So I highlighted here the end part, and what they reported is that participation in 5 or more seasons of endurance training, menstrual irregularity, the MI, BMI, and lean tissue mass were independent predictors of low bone mineral density. So a study like this, an epidemiologic study like this, one can report and give you an idea about how many or what proportion of athletes in a particular group, in this case adolescent competitive endurance athletes, so 13 to 18-year-olds, how many, what proportion, what percentage would be experiencing low bone mineral density at any point in time, and then highlighting potential risk factors. So finding these relationships between some of those factors I talked about before. And that's valuable information because now future studies can be done to see if correcting those particular risk factors or those measures improve bone mineral density in that population. And as I also mentioned, epi studies are filled full of tables and figures, and they really bring to life the data. Because sometimes, well, as you know, when you read research papers, sometimes they can be very dry, very scientific in their presentation, and especially in epi, there can be lots and lots of data. And so it's really nice to be able to visualize things in a well-designed table or a well-designed figure. And I think these are both great examples here. Now, did anybody get a chance to look at Yang et al.? So Yang et al. Is really interesting. And with this particular study, they're looking at an association. So is there a relationship between push-up exercise capacity and future cardiovascular events among active adult men? So what did the findings suggest? That a higher baseline push-up capacity is associated with a lower incidence of cardiovascular disease events. That's really fascinating. So you could potentially say push-ups are protective? Does that make sense? Does that make sense based upon what you might know about cardiovascular disease? What do we know as risk factors for cardiovascular disease? Things like age, genetics, smoking history, diet. So how do push-ups play into that? Well, we know that there are different exercise modes that can help to improve our cardiac disease risk profile. But what they're looking at here is they're saying that people who can do more push-ups are at a lower risk of cardiovascular disease events over a 10-year period. Does this mean you go right out and you tell your clients that they need to improve their push-up capacity? Does this mean individuals with bad shoulders, for example, or bad elbows, bad wrists, that those individuals, they have a greater risk of cardiovascular disease? My apologies there if you heard a family member in the background. So what occurred in this study, and this is what's really interesting about epidemiologic studies, is it's oftentimes you have got to be careful not to really blow things up. So in this study, what they did is looking at adult male firefighters. They had collected, as probably part of a baseline fitness exam, what their push-up capacity was. And then, looking at data that was available, looking at 10 years of data, follow-up data for cardiovascular disease events, they can go back and look to see if individuals who could perform more push-ups were at a greater or lesser risk. And again, they found that there was a reverse or inverse relationship. So more push-up capacity was associated with a lower rate of cardiovascular disease events. So what do you do with that? Well, or how do you interpret that? Do you say maybe individuals that can do more push-ups have general better fitness, and as part of that, they're leading a healthier lifestyle and doing other things like not smoking and eating a proper diet? Maybe. That would make sense. The challenge with a study like this is now, do you prospectively do a study? This was a retrospective study. Do you take the time and do a prospective study and you have people do push-ups to see if it improves their health? See, here's the other interesting thing about this study. They just looked at one point in time. What if those individuals who were working out and doing push-ups continued or didn't continue, or people who hadn't had a good push-up score started to change in their behavior in some capacity? So hopefully it's kind of giving you an idea that sometimes these epi studies that come out that can be these like really big, like wow things, and maybe we should change the way we do things, are sometimes just interesting. Just make you go, and make you think, okay, maybe I need more data. Maybe I need more research before I make a different determination. The purpose of this particular week is to gain an understanding of measures of disease or injury frequency, primarily looking at prevalence and incidence. The measure of health and disease is fundamental to the practice of epidemiology. A variety of measures are used to characterize the overall health of populations. Population health status is not fully measured in many parts of the world, and this lack of information poses a major challenge for epidemiologists. So first, what is health and disease? Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease. So when doing epidemiologic studies, researchers always need to define what health is and what is disease. Now, when it comes to disease, some definitions in epidemiologic studies can be very simple. For example, disease is absent or disease is present. An epidemiologist or a researcher who's doing an epidemiologic study would then categorize subjects based upon the presence or lack thereof of disease. It's important that you develop and include within your study, if you're doing something that is epidemiologic, what the operational definition is for that injury or illness. This will help you categorize subjects into either your sick or injured group or your not sick or not injured group. Basically, people who develop the disease or injury versus people who do not. So, here is an example of an operational definition that I've used in my research. Now, research-wise, the things that I like to do are to do preseason tests using functional tests to measure strength and agility, and really the general lower extremity functional strength or agility ability in Division III collegiate level athletes. So an injury is any muscle, joint, or bone problem of the low back or lower extremity that occurred during practice or competition via a non-contact mechanism that required the athlete to be removed from that day's event or to miss a subsequent practice or competition. So it's very specific there. And I'm looking at the general lower quadrant of the body, the low back down to the feet. And I'm wanting to make sure that somebody is injured via a non-contact mechanism and that there's time loss. So why is that important? Well, sometimes people who have done similar studies as mine, they will include contact mechanisms of injury. And there may not be any time loss. So maybe the athlete gets medical attention from the team's athletic trainer, but there's no time loss from sport. So the question is, if there's no time loss, is it really an injury? So this is the way that I believe I'm getting things to be as objective as possible. Now, I could make my focus only on one region of the body. I could be only interested in the knee, or I could be only interested in the ACL of the knee, for example. Why do I include the non-contact mechanism versus including contact mechanisms? Well, what I hope to show is that there's an association between the test that I do and future risk of injury. If that's the case, then improving strength or agility and observing that by improved scores on the test would hopefully lead to a reduction in injury risk. But with contact mechanisms, people can be in great fitness, get hit the wrong way or hit too many times, and may get hurt. So regardless of what discipline you're in, whatever population you're looking at, you want your operational definition to be as specific as possible. So again, strengths of my operational definition of injury include time loss and only having non-contact injuries. And a potential weakness is I don't have specific medical diagnoses sometimes. I just have muscle strain, ligament sprain, but it's limited to what the athletic trainer is able to give me versus maybe some of the tools that would be available to a primary care provider, MD, PA, somebody like that might have imaging available. Now, as clinicians, we may lack access to certain tools that allow us to optimize our ability to rule in or rule out a diagnosis. For example, anterior knee pain versus patellar tendinopathy. For those you that aren't familiar with orthopedics, anterior knee pain can be a term sometimes applied to individuals who are experiencing pain in the front of the knee. Patellar tendinopathy can also be experienced in the front of the knee, but it is associated with jumping sports like basketball and volleyball, and that athlete should have pain in the patella tendon area only versus more of a global pain experience. Well, if you're doing an epidemiologic study looking at risk factors associated with patella tendinopathy, you would need to have a diagnostic ultrasound machine. That would be really good because palpation, as I mentioned before, could be a way to say, yes, it hurts over the patellar tendon, but what if it also hurts and you palpate other areas in the anterior knee, and so it hurts in the patella tendon as well as around other parts of the knee? Or what if the individual doesn't have a lot of pain, but if you do ultrasound imaging, it shows you an unhealthy tendon? Several measures of disease frequency are based on concepts of prevalence and incidence. Prevalence and incidence help to answer these questions. What proportion of a group of people has a condition? And at what rate do new cases arise in a defined population as time passes? You'll hear people use prevalence and incidence sometimes interchangeably, but that's a very incorrect use of the terms. Now, we'll describe prevalence and incidence more in just a bit, but first, let's talk about the population at risk. People who are susceptible to a disease or an injury are the population at risk. When doing a study looking at injuries in high school athletes, for example, you would only include high school athletes and not college athletes in that mix. You wouldn't include females, biologic sex females, in a study involving the prostate. You most likely wouldn't include non-runners in a study looking at risk factors for running-related injuries. And you wouldn't include males, biologic sex male subjects, in a study looking at cervical cancer. So it's important to make sure the population you're interested in is as homogeneous as possible. Let me give you an example. I have done studies looking just at Division III athletes. I've also had studies that have included athletes from NAIA schools and Division II schools. When I've included those other athletes, people could make the argument that, well, they're different athletes because skill-wise, athletes would go to one school versus the other. But then the counter argument would be maybe the reason athletes are going to a particular school is because of the academics and not necessarily because of the level of competition. And so I try to focus on smaller schools, smaller institutions, and I feel that I can make a good argument that way. I would not want to, for example, compare athletes or include athletes from my Division III school, George Fox University, with athletes from the Division I level like the University of Oregon or Oregon State University. Those athletes may be very different, and if I mix those athletes, I might not get a clear picture of risk, of injury risk, because of the variability between the different skill sets. Let's now talk about measures of disease frequency. So I've said before, prevalence and incidence. Prevalence, these are our cross-sectional studies where you're looking at a proportion or a percent of a group of people possessing a clinical condition or outcome at a given point in time. There are two types of prevalence that we'll look at. There is point prevalence, which is measured at a single point in time for each person, and period prevalence, which includes all the cases that were present at any time during a specific period. And let's talk about incidence. What is incidence? These are the studies which find a fraction or proportion of a group of people who are initially free of the outcome of interest or the disease of interest or the injury of interest that develops that condition, that outcome, that disease over a period of time. And there are two that we will explore here, cumulative incidence and incidence density. I'm going to pause the recording here. When you're ready, move on to part 2.